Benvenuto.
Grazie, grazie. Thank you, Professor Papadakis,
I'm
and
not
my
a professor.
friend, Doctor.
I'm only a simple
Dr.
doctor.
Gregorio, yes. And my friend, Dr. Lazarus Papadopoulos. I'm very happy to stay here. Sorry, but I don't speak Greece. If you want to speak Italian, but I think it's better English, no? So my topics today is it's a big question because in the world we try to omission the axillary dissection, the early breast cancer, but it's not so easy because in the real world the number of axillary dissection is much more today. So I think to try to explain if I think it's really important in some case the omission of axillary dissection. All we know the guideline, the American guideline, NCCN, when in the, could I have the total screen in my PC? Sorry? Could I have the total screen? Thank you. Okay. And all you know, the NCCN guideline on the breast conserving surgery after and following radiotherapy for early breast cancer. And you can see that today is really important, the omission of axillary dissection, but with radiotherapy. And so is the ultimate guideline of NCCN. But the other important and famous guideline, like ESMO Clinical, and you can see that in this case, further axillary surgery following macrometastasis in sentinel lymph node not required axillary dissection, but radiotherapy with tangential exposition. Also, the NICE guideline, the British NICE guideline, it's important to discuss with the patient the benefit and risk of the omission of axillary dissection in this case of breast cancer. So, remain the axillary dissection very important to stage the breast cancer, but the management of the axilla today has shifted towards a more conservative approach. Why? For a significant risk of complication with this kind of surgery, and also the minimal invasive and less morbid procedure of sentinel lymph node biopsy today in many cases replaced axillary dissection, especially and sure in node-negative breast cancer axillary staging. Today, complete axillary dissection now be considered over treatment for early stage breast cancer, and this recommendation starts being challenged based on some following consideration. The first is that today the diagnosis tends to be earlier by screening mammographic. Less than half of patients, remember, with sentinel lymph node metastasis present additional metastasis. And the majority of sentinel-positive patients not undergoing axillary dissection will receive chemotherapy and or endocrine treatment and also radiotherapy. All we know, this famous study, the Giuliano study, Z11 study from the American College of Surgeons, and in case of breast-conserving surgery, patient and the whole breast radiotherapy, patient with 1 or 2 metastatic lymph node was randomized in the axillary dissection or no further axillary treatment. And this study, there are many controversies, and one of these was the premature enrollment conclusion. Too many patients lost to follow-up. Half of the patients presented micrometastasis, so a very low burden of cancer. and the lack of radiotherapy quality assurance with missing data for more than 2/3 of randomized patients. So we don't have data of the radiotherapy in this patient. For this and other situation, some years ago, start in Europe many trials similar to Z11, and this is the name of this study. The POSNOC trial, it was an English trial that confront axillary dissection with radiotherapy, in this case of patient with breast conserving surgery. The BOOK trial was a Dutch trial that confront mastectomy without axillary dissection with mastectomy with radiotherapy of the axilla. The CENOMAC trial, a Swedish trial, very similar to POSNOC trial, and the INSEMA trial, Deutschland, that you can see the design trial confirm and confront surgery with radiotherapy in this case of patient. Also in Italy, for the problem of don't use the data of Z11 in the clinical Italian breast unit, we start this kind of study, and the name was Synodar 1 trial, and this is the paper of presentation in the world, an ongoing randomized clinical trial to assess the role of axillary surgery in breast cancer patient with 1 or 2 micrometastatic sentinel node. The study started in 2015 and ending the enrollment in April 2020. And this is the study design. You can see T1, T2, N1 with 1 or 2 macrometastatic surgery, any kind of surgery, not only conservative surgery, but also mastectomy. And these patients were randomized in the axillary dissection or not axillary dissection. And all the patients after were discussed at the MDM meeting and defined the other therapy for the case of patient. This is the data. The number of patients of this trial was the same of Giuliano study, so the population is sufficient. And this is the 2 arm. There are a good balance in the 2 arm of patient. And this is a very important slide because you can see the data about the axillary situation in this patient, and you can see in the standard arm that there was 44% of metastatic non-sentinel node 1. So it's very important to know this data because it's online with the literature on the axillary involvement of this kind of patient. Remember this data. This is the other slide regarding T surgery, and you can see that maybe the 80% was breast conserving surgery, but we are a good number of mastectomy in all the arm of this patient. And this is the events after 4 years of follow-up in the 2 arms. And you can see that there is no statistically significant difference in terms of survival and regional recurrence between the 2 different groups of treatment. So there is no difference in terms of regional recurrence. This is the long-term oncological outcome, so this is very, very good, important data, and this is the long-term oncological outcomes and vision of intention to treat population and per protocol population. So it's very safe, this kind of study for the patient. The evaluation after 4 years of regional recurrence is very important because you can see in this slide there are a few publications about this kind of problem, and you can see that there is no many number about the regional recurrence in the patient that are omission of axillary dissection. And you can see that in the Giuliano study, after 2 years of follow-up in the arm of sentinel lymph node only, there was 2 axillary relapse. So the data of Synodar 1 is really, really very important to confirm the data of Giuliano study. But the really important of this study is the clarify to the situation of controversy of the study of Giuliano. You can see the number of micrometastases that in the Giuliano study was very high, and in our study is very low. Another important data was the mastectomy, that in the Giuliano study there aren't, and the data of radiotherapy, that in our study is very important. This is a famous paper recently published in Annals of Surgery, a big American journal, and you can see that important of this data in the American situation. This is the previous presentation at San Antonio of the last years of the data, the preliminary data of this study. In Italian, after the publication of the data of Synodar, we changed the practical of axillary dissection. This is the Italian guideline, and I think that Gregorio knows this kind of Italiano. And you can see that today there is a strong recommendation to omission axillary dissection in this kind of patient. So this study changed the surgery in Italy for the patient in Synodar 1 trial. I think that today we must to think about our surgery for this patient, because there are the ethical problem to continue to axillary dissection this kind of patient. I think it's very important, this situation. Today, we omit the axillary dissection in all these patients, but not only in Humanitas, also in the majority of breast unit in Italy, because we try the indication of Italian guidelines of the oncology statement. But this is not the stop of our study. We continue the Synodar 1 only for the mastectomy, because we think that it's very important also in the patient with a little breast without axillary involvement. If you perform a mastectomy, maybe it's very important to the omission, also in this case the axillary dissection. So we continued the new clinical trial designed as a single-arm experimental study in which all patients will be treated without axillary dissection. This is the study design. The study is open, and in all the Italian breast unit, we conduct this kind of study. This is the number of the study over the next 3 years with a follow-up of 5 years. The first patient of the second number of patients, not only the Synodar 1 patient, but other patients, starting in June 22, and the primary endpoint was locoregional disease and distant disease-free survival. Thank you. I like. Conosco il greco, maybe. Thank you for the invitation. Thank you.
Thank you so much for your very important speech. We are honored to be here. It's a lecture, so I think that we would not have the opportunity of questions, but a small comment from me is that your study is very, very, very important, although we all think that the method of omission of axillary lymph node dissection is established in the majority of breast units throughout the world. Your study has a very big impact, showing data from the real world, and in a prospect way. Yeah. So it's very interesting, and we are waiting for your final results with great interest.
Thank you.
Thank you again.
Thank you. Thank you. Musk.
Any other questions? Κύριος Άσκο Ξυλάκης. Πρόσεχε τι θα πεις.
In italiano, se vuoi.
It's difficult for the others. Okay?
Yes.
Do you think that axillary lymph node dissection has any curative effect on the treatment of breast cancer?
Έχει μικρόφωνο εκεί, δικαίωμα.
Yes, it's a good question because the high number today of another axillary dissection is strange because I think that the clinician knows that axillary dissection it's only a staging of the axilla. It's important for other therapies, but not for survive the patient. So I think that all the information that we need we have with the sentinel node biopsy. In these days, you know, we have many pharmacological studies like abemaciclib or other kind of new drugs that need the number of micrometastases in the node for decide to use this new drug. I think it's an anti-historical position, this, and we change this kind of decision, and they use the genomic test for define the high or low risk for chemotherapy and this kind of new drug. But in the luminal cancer, they try to leave the axillary dissection like staging, but I think it's not important, absolutely.
In the next few years, we'll abandon even lymph node, sentinel node, just because of the molecular biology and new ways of evaluating breast cancer and treating it. Lymph nodes and lymph node dissection must die.
Yes.
Thank you.
But
Yes?
maybe surgery, maybe surgery must die because
surgeons
now,
in general.
now in San Antonio, you know, many oncologists prepare the new drugs for avoid the surgery in this patient. I think it's a long way, especially in the hormonal subtype. But in the triple negative, in the HER2 positive patient with complete pathological response, many trials start to avoid surgery in this kind of patient, especially in the axilla. I think that the patient with N0 clinical and instrumental today, I wait the data of sound trial, you know sound trial for Yale, and I hope that, but in the early breast cancer,
Gentilini.
yes, in the early breast cancer, Paolo Veronesi. In the early breast cancer, I think that the axillary staging maybe is not to avoid.
So we, for the moment, can keep axillary dissection only for staging
Yes, sure.
purposes.
But
Thank you.
not all surgeons maybe are
It's 20 years ice cream.
after neoadjuvant maybe.
One more question from Mr. Papadopoulos.
First of all,
And we're finished.
I think it has, thank you so much for being here. It's a great honor to have you here. And what you've done in Humanitas, I think it has changed research in Italy from IEO. Now it's starting to moving towards you. It's not just Synodar 1, it's the Neonode 1 that you are doing right now, which is micrometastasis, I think, after neoadjuvant chemotherapy, concerning to what we've said with the axilla before. But I would like to ask something, because it's very, very important what we mean by clinically negative axilla. How would you say, because in the Z11 it was palpation,
Yes.
what were the tools that you used to identify a clinically negative axilla?
Yes.
Thank you.
I think that all these patients must submit an echography. Echography is really important and have a high sensibility for this kind of problem. And maybe with cytology if there is some suspect. But the echography and the clinic in this kind of patient, early breast cancer, I think it's very important.
Yes, it's important.
Before surgery.
If I may, it's important, but it cannot exclude the patients from the setting of the Z011, because finding a pathologic node in echography and may also in FNA must
Yes.
not exclude this patient
No.
from omitting ALND.
Yes.
Do you agree?
Yes, yes, I am totally agree. There's a question?
Okay, we finished?
There's a question from internet.
There is a question?
From internet.
Yes, there is a question from internet.
Yes. It says that how many patients with... Sorry. There's a question from Mr. Salustros asking for how many patients with 1 to 2 positive lymph nodes in the axilla dissection group found to have more positive nodes. I'm thinking that the 11 was almost 30%, more than 1 node positive, right?
Yes.
In your trial, I think it was...
Yes, there is a, wait. This slide is very important. You can see in this slide the number of other, wait, here. In this slide, you can see the other number of node, and in 44%, there was another macrometastasis in the lymph node, and the number of 3 nodes positive was 9%. So very, very small number of high number of micrometastases. But I think that the follow-up of this study confirm that the clinical importance of this macrometastasis is not so high, because this patient don't have a regional recurrence. So this patient have another therapy, radiotherapy, medical therapy that probably control this kind of macrometastasis. So I think that it's not necessary axillary dissection for other maybe pathological nodes in the axilla in this kind of patient, not neoadjuvant patient, this kind of patient.
Okay, thank you. Thank you. Thank you very much.